So what is consolidation? Consolidation means solidification of the lung tissue due to accumulation of solid and liquid materials like blood, cells, fat, gastric content, protein, pus, conjugate, water in the air space that would have normally been filled by air. But instead of air, there is presence of these things: blood, cells, fat, etc. That is called consolidation. Cause, acute cause, chronic cause. Acute cause, acute inflammatory exudate like pneumonia, cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, hemorrhage, aspiration pneumonia, infarction. Chronic cause, post-obstructive pneumonia, bronchoalveolar carcinoma, lymphoma, bronchiolitis obliterans, eosinophilic pneumonia, sarcoidosis, and alveolar proteinosis. Now, the pneumonia. Pneumonia is defined as acute inflammation of the lung parenchyma distal to the terminal bronchioles, consisting of respiratory, bronchial, alveolar ducts, alveolar sac, and alveoli. The two commonest cause of consolidation, one is pneumonia, that is lobar pneumonia, and bronchogenic carcinoma. First is pneumonia. Etiology classification: bacterial pneumonia, lobar pneumonia, and bronchopneumonia or lobular pneumonia. Then legionella pneumonia, viral and mycoplasma pneumonia, fungal pneumonia, cause pneumocystis pneumonia, others. Non-infective pneumonia, aspiration pneumonia, hypostatic pneumonia, lipid pneumonia. Bacterial pneumonia has two patterns of anatomical distribution. One is lobular bronchopneumonia and lobar pneumonia. Lobar and lobular. Patchy consolidation of the lung is the dominant characteristic of bronchopneumonia or lobular pneumonia. And consolidation of large portion of a lobe or of an entire lobe defines as lobar pneumonia. So lobar pneumonia, one lobe is involved, that is called lobar pneumonia. And lobular pneumonia or bronchopneumonia is patchy consolidation of the lung. This is bronchopneumonia and it is lobar pneumonia. A lobe is involved. This is bronchopneumonia. These are the lobular pneumonia or bronchopneumonia. Patches of consolidation, this area are consolidation. So consolidation means solidification. This is lobar pneumonia. Gray hepatization, lower lobe is consolidated. This is the area of consolidation. So this is lobar and it is lobular. Now the pneumonia syndromes: cause, community acquired acute pneumonia, cause Streptococcus pneumoniae, Haemophilus influenzae, Morazzola alteralis, Staph aureus, Legionella pneumophilia. Healthcare associated pneumonia, Staphylococcus aureus, methicillin sensitive and methicillin resistant, Pseudomonas aeruginosa, strep pneumonia. Hospital acquired pneumonia, cause is gram-negative rods, Enterobacteriaceae, Staphylococcus aureus. Now the morphologic features. There are four stages. First is stage of congestion, that is initial phase. Then red hepatization or early consolidation. Then gray hepatization or late consolidation. And resolution. First is stage of congestion or initial phase. This phase last up to for 1 to 2 days. It is represent early acute inflammatory response. Grossly affected lobe is enlarged, heavy, dark red, and congested. Part surface exudes blood-stained, frothy fluid. Histologically typical features of acute inflammatory response to the organisms are seen. These are number 1 is dilatation and congestion of the capillary in the alveolar wall. Number 2 is pale eosinophilic edema fluid in the air space. Number 3 is a few red cell and neutrophil in the intra-alveolar fluid. Number 4 is numerous bacteria. So, this is the stage of congestion. Enlarged and heavy lung. These are the neutrophils and RBCs. These are RBCs, these are neutrophils. These are edema fluid. Now second stage, red hepatization or early consolidation. This phase lasts for 2 to 4 days. The term hepatization in pneumonia refers to liver-like consistency of the affected lobe on dissection. Grossly the affected lobe is red, firm, and consolidated. The back surface of the involved lobe is airless, red pink, dry granular, and has liver-like consistency. That's why it is called hepatization, red hepatization, because it has liver-like consistency. That's why this name, red hepatization. Histological features. Edema fluid of the preceding stage is replaced by strands of fibrin. There is marked cellular exudate of neutrophil and escavation of red cell. Many neutrophils show industриc bacteria. Alveolar septa are less prominent. So, these are the neutrophil and RBC, many RBC. And these are the fibrin strands. Now, third stage, grey hepatization, left consolidation. This phase lasts for 4 to 8 days. Grossly affected lobe is firm and heavy. The cut surface is dry, granular, and grey in appearance with liver-like consistency. The change in color from red to grey begins at the hilum and spreads towards the periphery. Histological features, fibrin strands are dense and more numerous. Cellular exudate of neutrophil is reduced due to disintegration of many inflammatory cells. This is the gross picture of Lobar Pneumonia, grey hepatization. This is. Here you can see the neutrophils, fibrin strands, these are fibrin, these are the alveolar wall, and these are macrophages. Now the fourth stage or last stage, that is resolution. This stage begins by 8 to 9 days if no chemotherapy is administered and completed in 1 to 3 weeks. However, antibiotic therapy induced resolution on about 3rd day. Grossly previously solid fibrinous constituent is liquefied by enzymatic action. Histological features, number 1 is macrophages are the predominant cells in the alveolar spaces, while neutrophils diminish in number. Many of the macrophages contain enlarged neutrophils and debris. Granular and fragmented strands of fibrin in the alveolar spaces are seen due to progressive enzymatic digestion. Alveolar capillaries are enlarged. So, you can see these are the congested area, these are the macrophages. These all are macrophages. So, bronchopneumonia or lobular pneumonia. These are the features of Lobar pneumonia. This is the lobular pneumonia or bronchopneumonia. Bronchopneumonia or lobular pneumonia is infection of the terminal bronchioles that escape into the surrounding alveoli, resulting in patchy consolidation of the lung. Here the consolidation is patchy type, patchy consolidation. The condition is particularly frequent at extremes of life, that is in infancy or old age, or due to influenza measles. Etiology: staphylococcus, streptococcus, pneumococcus, Klebsiella pneumoniae, Neophilus influenzae. Morphologic features: patchy areas of red or grey consolidation affecting one or more lobes, frequently found bilaterally. More often involves the lower zone of the lung due to gravitation of the secretion. On gut surface, these patchy consolidated lesions are dry, granular, firm, red or grey in color. Histological features: acute bronchiolitis, suppurative exudate consisting chiefly of neutrophils, thickening of the alveolar septa by congested appearance and lymphocyte infiltration. So, these are the edema fluid, these are neutrophils, congested areas, bronchioles, and these are the neutrophilic exudate in the bronchiole. Now, the bronchogenic carcinoma. Lung cancer is the most common primary malignant tumor in men and accounts for nearly 30% of all cancer deaths in both sexes in developing countries. Currently, the incidence of lung cancer in female in the United States has already exceeded breast cancer as a cause of death in women. Etiology: etiology is cigarette smoking. The main etiology, most but not all, is cigarette smoke. In addition, there are other genetic and environmental factors. Lung cancers are broadly classified into small cell and non-small cell types. In the non-small cell, adenocarcinoma, squamous cell carcinoma. But lung cancer can occur the person who never smokes. The WHO estimates that 25% of lung cancer worldwide occur in never smokers. These cancers occur more commonly in women and most are adenocarcinomas. Cancer in non-smokers are more likely to have EGFR mutations due to EGFR mutations. And these are the types of adenocarcinoma. Clinical features: major features are cough, weight loss, chest pain, and dyspnea. Now the WHO classification of lung tumors. First is epithelial tumor. In the epithelial tumor, adenocarcinoma. In adenocarcinoma, minimally invasive adenocarcinoma of the lung, invasive non-mucinous adenocarcinoma, invasive mucinous adenocarcinoma, polar adenocarcinoma, fetal adenocarcinoma, enteric adenocarcinoma. Squamous precursor lesion, squamous dysplasia and carcinoma in situ, squamous cell carcinoma, and lymphoepithelial carcinoma of the lung. Large cell carcinoma and adenosquamous carcinoma. Now, lung neuroendocrine neoplasm. Precursor lesion, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, neuroendocrine tumor, carcinoid and neuroendocrine tumor of the lung, neuroendocrine carcinoma, small cell lung carcinoma, large cell neuroendocrine carcinoma of the lung. There are some uncommon types: sarcomatoid carcinoma. Adenocarcinoma is the most common, 50%, then squamous cell carcinoma, then small cell carcinoma, then large cell carcinoma, other. Morphology. Lung carcinoma may arise in the peripheral lung, more often adenocarcinoma, or in the central or hilar region, more often squamous cell carcinoma. So it can be from peripheral or from central hilar region. Adenocarcinoma is an invasive malignant epithelial tumor with glandular differentiation or mucin production by the tumor cell. Adenocarcinoma, there are various patterns of growth like acinar, lipidic, papillary, micropapillary, and solid. Compared with squamous cell cancer, these lesions are usually more peripherally located and tend to be smaller. They vary histologically from well-differentiated tumor with obvious glandular elements to papillary lesion resembling other papillary carcinoma to solid masses with only occasional mucin-producing gland and cell. Mucinous adenocarcinoma tend to spread erogenously, forming satellite tumors. They may present as a solitary nodule or as multiple nodules. Or an entire lobe may be consolidated by tumor mimicking lobar pneumonia. This is the gross picture of lung carcinoma. Here is the mass. The grey-white tumor infiltrates the lung parenchyma. This is the picture of adenocarcinoma in situ, mucinous subtype. Here there is no invasion. Gland forming adenocarcinoma. You can see lots of glands are present here. And that glands are malignant glands. Now squamous cell carcinoma. Squamous cell carcinoma is more common in men and strongly associated with smoking. Precancerous lesions that give rise to invasive squamous cell carcinoma are well characterized. Squamous cell carcinoma are often amputated when squamous metaplasia or dysplasia in the bronchial epithelium, which then transforms to carcinoma in situ, a phase that may last for years. Histological features: presence of keratinization and or intercellular bridges or keratin pearl will be present. Keratinization may take the form of squamous pearl, or it is also called keratin pearl, or individual cells with markedly eosinophilic cytoplasm. These features are prominent in well-differentiated tumors, are easily seen but not extensive in moderately differentiated tumors, and they are focally seen in poorly differentiated tumors. Means keratin pearl, if present, then it will we will call well-differentiated tumor. If it is moderately present in few numbers, then it is moderately differentiated tumors. If it is absent or very minimum present, then it is called poorly differentiated tumors. This is the keratinization or keratin pearl. These are the malignant squamous cells. These are the keratin pearl. It is well differentiated squamous cell carcinoma. You can see these are all malignant squamous cells. Now small cell carcinoma. Small cell carcinoma is a highly malignant tumor with a strong relationship to cigarette smoking. Only about 1% occurring non-smoker. Tumor may arise in major bronchi or in the periphery of the lung. Small cell carcinoma is composed of relatively small cell with scant cytoplasm, ill-defined cell organs, finely granular nuclear chromatin. That is called Salk-Pepper pattern. Salk-Pepper chromatin. And absent or inconspicuous nucleoli. There is no absolute size for the tumor cell, but in general they are smaller than 3 times the diameter of a small resting lymphocyte. The mitotic count is high. The cell grow in cluster that exhibit neither glandular nor squamous organization. necrosis is common. It is small cell carcinoma. Areas of necrosis and islands of small, deeply basophilic cells. This. Now, large cell carcinoma. Large cell carcinoma is an undifferentiated malignant epithelial tumor that lacks the cytologic features of other forms of lung cancer. The cells typically have large nuclei, prominent nuclei, and moderate amount of cytoplasm. Large cell adenocarcinoma is a diagnosis of exclusion, since it expresses none of the marker associated with adenocarcinoma, that is PTF1, vaccine A, or squamous cell carcinoma, that is P40, P63. One histologic variant is large cell neuroendocrine carcinoma, which has molecular features similar to those of small cell carcinoma. Large cell neuroendocrine carcinoma is different, and large cell carcinoma is different. This is the intent cell. These are large cells, large malignant cells. These are pleomorphic and show no evidence of squamous or granular differentiation of chromatin.